I am Dana Edmonds, and I'm honored to present my Doctor of Nursing Practice project with you, titled Educational Intervention and Assessment of Knowledge about Gestational Diabetes. This project centers on empowering pregnant individuals through structured education to improve outcomes in gestational diabetes mellitus, or GDM. As a nurse, I have witnessed how information or lack of it can drastically impact patients' outcomes. Education is more than just instruction. It's about giving people the tools to care for themselves with confidence. So today I want to walk you through how one focused, culturally sensitive session made a meaningful difference. Committee members. This project would not have been possible without the support of my wonderful committee. I want to sincerely thank Dr. Teresa Galakatos, my chair, for her mentorship, wisdom, and tireless encouragement. Thank you also to Tracy Edmonds, my community representative, who insight kept this project grounded in real-world relevance. And of course, thank you to Dr. Lisa Steer, my second reader, for her valuable feedback throughout the process. Your support helped transform this idea into action. My bio. To share a bit about my journey, my nursing career began after I earned my BSN from the University of Texas at Arlington. I then went on to work on my MSN, and I'm currently in the DNP program at Maribel University. I work in the NICU in the Medical City Plano, and I have cared for many infants affected by gestational diabetes. The NICU gives you a front row seat to the impact that maternal health has on newborns, from respiratory issues to complications related to blood sugar regulation. These experiences show me the urgent need for prevention and education, and that's what inspired me to do this project. Introduction. Gestational diabetes mellitus, GDM, is more than just a pregnancy complication. It's a public health issue. GDM affects between 5 to 10% of pregnancies in the United States and contributes significantly to both maternal and neonatal morbidity. The complications are wide-ranging, from macrosomia, which increases the risk of birth trauma, and C-sections, to neonatal hypoglycemia, which can lead to seizures and long-term developmental issues. Additionally, women with GDM are at a higher risk of developing type 2 diabetes later in life. What's frustrating is that many of these outcomes are preventable with the right education and support. Despite clear guidance from organizations like the CDC and ADA, educational practices are not standardized, and many patients feel lost in a system that overwhelms them. This project emerged from that gap, the need to deliver concise, personalized, and culturally competent education that actually reaches patients where they are. Purpose and aims. The purpose of this project was to assess how a structured, culturally sensitive educational intervention could enhance self-management practices among pregnant individuals diagnosed with GDM. The overarching goal was to empower patients to take control of their health using knowledge and confidence. The specific aims were fivefold. 1. To improve knowledge related to GDM management. Number 2, to increase adherence to glucose monitoring and reporting. Number 3, to boost self-confidence and perceived ability to manage GDM. Number 4, to promote lifestyle modifications, including diet and physical activity. Number 5, to evaluate patient satisfaction with educational experience. This project was built not only to inform, but also to inspire change among patients diagnosed with GDM. DMP question. Every strong project begins with a focused clinical question. My DMP question was, in pregnant individuals diagnosed with GDM, how does a structured educational intervention combined with glucose monitoring affect knowledge, confidence, and adherence to self-management over a 4-week period? This question served as a compass throughout the project. It ensured that everything I implemented was geared toward real-world application. Measuring whether patients actually learned, felt more capable, and applied those skills in their daily lives. This question is especially meaningful in today's healthcare climate, where we emphasize not only outcomes but also the patient's experience. Theoretical framework. Bandura's self-efficacy theory was the perfect framework for this project. This theory emphasizes the role of self-belief in behavior change. If a person doesn't believe they can accomplish something, like managing GDM, they are unlikely to try. So my session was designed to not just to teach information, but to build confidence. We talked through obstacles, created personalized strategies, and provided tangible tools to manage glucose. For example, instead of saying avoid high carbs, I use visual portion guides and share recipes that align with cultural preferences. The participants didn't just leave with facts, they left with practical strategies that felt doable. This is exactly what Bandura means by increasing self-efficacy. Review of literature. The literature review affirmed everything I was saying in practice. Multiple studies that I found helpful show that culturally tailored education results in higher patient engagement and better outcomes. The ADA also supports structured education as a foundation and basic and elemental of GDM care. Research highlights that when education includes real-world scenarios and culturally relevant content, it resonates more deeply. One major gap noted in the literature, however, is a lack of follow-up beyond pregnancy. Most interventions stop at delivery, even though the risk of developing type 2 diabetes later is real. This review shaped the design of my intervention and the recommendations I will share later today. Methods and design. I use a quantitative exploratory design. This approach was ideal for identifying trends and measuring effectiveness in a relatively small group. Participants attended a 1-hour in-person educational session that included core topics: GDM pathophysiology, healthy eating, strategies, the importance of physical activity, and step-by-step glucose monitoring. The session was designed to be culturally sensitive and easy to understand, with a heavy emphasis on visual learning. Participants received a CDC-approved pamphlet that they could take home. This ensured continuity and served as a reminder of what they had learned. Sessions also include an open questions and answers, allowing for real-time clarification and patient-led dialogue. Sample description. My sample included 50 pregnant individuals, aged from 20 to 35 years old, all diagnosed with GDM. They were recruited from a busy maternal outpatient clinic located in a diverse urban area. Participants came from various cultural and socioeconomic backgrounds, including Hispanic, African American, and Southern Asian communities. Many work full-time and were balancing jobs, family, and pregnancy. This diversity made cultural relevance a necessity, not an option. Every piece of material used had to be adaptable and respectful of different dietary practices, beliefs, and learning preferences. Inclusion criteria require an official GDM diagnosis, English proficiency, and the ability to attend a single educational session. Data and collection and analysis. Data collection was done through pre- and post-surveys, evaluating knowledge and confidence. Glucose monitoring logs submitted weekly and a patient satisfaction survey administered at 4 weeks. The Wilkinson sign rank test was chosen for statistical analysis because it's ideal for comparing two related samples, such as pre- and post-intervention data in non-parametric distributions. It was used to determine whether there was a significant improvement in knowledge and confidence scores. Descriptive statistics help interpret glucose readings and satisfaction levels. This combination gave me a robust picture, both numerically and qualitatively, of how the intervention performed. Results knowledge. This graph shows pre- and post-intervention knowledge scores. The average score jumped from 3.2 to 4.7 on a 5-point scale. That's a statistically significant increase with a p-value of less than 0.001. Participants answered questions on normal glucose ranges, dietary risk, timing of blood sugar checks, and the long-term implications of GDM. They show the most improvement in questions related to food choices, especially identifying hidden sugars and carbohydrate counts. This shows the power of simple, hands-on teaching. For example, comparing rice portion sizes and showing label examples made a big difference in comprehension for patients. Results: glycemic stability. This bar graph shows fasting post-breakfast, post-lunch, and post-dinner, glucose values before and after the intervention. While the changes weren't statistically significant, the trend was favorable. Most participants maintained glucose levels within the normal range through the 4 weeks. The red dots on the graph represent individual participants' results. Dots that descend downward indicate improvement. The greatest glycemic improvement was observed in post-dinner levels, likely because the session specifically addressed challenges with evening eating habits like skipping meals or choosing high-carb comfort foods. This is a clear clinical win. It shows that even small educational tweaks can lead to behavior changes. Patient satisfaction. Patient satisfaction was overwhelmingly positive. 85% reported increased confidence in managing their GDM, and the average satisfaction score was 4.7 out of 5. Many participants said that they felt the session was the first time someone truly explained GDM in a way that made sense to them. They appreciated the non-judgmental tone, the visuals, and being able to ask questions openly. One mother told me she had been terrified of her diagnosis, but left the session feeling calm and in control. That shift from fear to empowerment is hard to measure statistically, but it's perhaps the most meaningful outcome of all. Interpretation of results. These findings suggest that a brief, well-designed intervention can meaningfully impact both understanding and emotional readiness. Knowledge increased, glucose levels stabilized, and patients left feeling empowered. It's worth noting that behavior change takes time, so we wouldn't expect massive glycemic changes in just 4 weeks. However, the maintenance of healthy level is still a positive indicator. The upward trend in knowledge and the downward trend in glucose readiness, especially after dinner, suggests real lifestyle adjustments were already taken in place. And if those changes can be sustained, the benefits for maternal and fetal healthcare are tremendous. Limitations. There are a few limitations to acknowledge. First, the small sample size limits general visibility, and all participants came from a single outpatient site. Second, the follow-up was short, just 4 weeks. This prevented us from evaluating whether behavior changes were sustained long-term. Third, glucose readings were self-reported, and though participants were encouraged to record them honestly, self-report bias is a possibility. A longer-term study using continuous glucose monitoring at multiple clinical sites will provide more comprehensive data. Despite these limitations, the intervention shows strong potential and future improvements that could make even more impactful. Discussion. Overall, this project supports the idea that patient-centered nurse-led education works. It strengthens knowledge, builds confidence, and promotes stability in chronic conditions like GDM. This project also reinforces the nurse's role not just as caregiver, but as educator, advocate, and partners in patient health. When we empower patients with tools they understand and believe in, they rise to meet the challenge. If scaled, this type of program could fill a major gap in current prenatal care by making education both accessible and actionable, and not only on this topic but in other topics of health as well. Implications for practice. The results have real-world relevance. Nurses can lead these educational interventions as part of routine prenatal visits. They can also identify at-risk patients earlier and connect them with resources tailored to their needs. In the future, these sessions could be offered virtually, increasing access for rural or underserved populations. Additionally, incorporating mobile apps for tracking, reminders, or even virtual groups coaching could provide a 24/7 support for patients. This isn't just a theory, it's a practical, scalable way to transform patient care. Conclusion. This project showed that structured culturally appropriate education can create meaningful change in how women understand and manage gestational diabetes. This project improved knowledge, enhanced confidence, and supported glycemic stability. But beyond that, reminded me why I chose nursing. We are uniquely positioned to bridge gaps, empower families, and influence lives far beyond the bedside. This project gave me the chance to step into that role more fully. I'm committed to continuing this work in every part of my practice. Future recommendations. Moving forward, I recommend spending follow-up window to 3 to 6 months to evaluate the sustainability of knowledge and behavior changes. Current care protocols often stop after delivery, but the risk of developing type 2 diabetes remains high. We need to include postpartum education and screening as a standard part of care. I also plan to explore digital tools such as text message, check-ins, online meal trackings, and peer support groups. Finally, I will advocate for policy change because making education reimbursable isn't just good healthcare policy, it's the right thing to do for healthcare, for our patients, and for our community. DMP Essentials Reflected. This project embodies all 8 DMP essentials, from applying scientific underpinning and leading system change to using data for improvement and practicing cultural humility. But it was essential number 8, advanced nursing practice, that touched me the most. I remember one participant in particular. She was tearful, afraid, and overwhelmed. But after the session, she smiled and said, "I can do this." That's advanced practice, meeting people where they are, walking beside them, and lifting up. That's the nurse I strive to be, and this project helped me become her and be more useful to all our patients and for the future of nursing. Questions. Thank you all so much for your time, interest, and support. I would love to open the floor for any questions or thoughts. Whether you are curious about the methodology, interested in implementing something similar in your own practice, or have insights from your own experience working with GDM patients, I welcome the conversation. My goal is to continue learning and collaborating, and this dialogue is just as important as the research itself. Here is my email information, so be free to email me or contact me at any time. I will be happy to answer you and exchange ideas about this. References. These references supported my research and help guide the structured evidence base for my intervention. I would also like to thank and acknowledge the CDC for providing high-quality educational materials that were used in this project. Research is a team effort, and I'm incredibly grateful for the scholars, clinicians, and patients whose contributions help shape this work. Thank you again for your attention today, and I wish you the best.